So I work with Karen Swinson, who is our national lead for nursing productivity, who's not here today, and also with Nyasha Maria, who's our CHPPD lead. Also, he's not able to be here today, but I'm sure his people are watching me today and everybody else here today. So what we're going to talk about in this session is we've had some really good sort of setting the landscape around establishment setting, but as many of you will know, and I know many of you in the room today as well, one of the biggest challenges is that you sort of go through the process of establishment setting, but then you have to get into the nitty-gritty to make sure that your software that you use to set your rosters, so we've got getting your rosters right, but we should be doing e-rosters, can be a bit of a struggle. So I'll just give you a little bit of a background. So whilst we work, the nursing productivity team work very closely with Mark and Anne's team within NHSI. We sit within the Operational Productivity Directorate, which was created, for those that are aware, Lord Carter did a review into unwarranted variation, and one of the outcomes of that report was very much around productivity of the nursing workforce and particularly around e-rostering and the deployment of staff as well. So we, and my role and also Nasha's role in terms of CHPPD is very much around looking at using the tools that we've developed in alignment with some of the establishment tools as well to try and look at making the best of our workforce and maximising our workforce, but also to do it in a way that very much is outcome focused for the patients. So this is an example of some of the sort of overall summary of what we do. It's really about optimising the use of e-rostering, building on establishment setting and developing systems to match CHPPD to CHPPD demand. And my colleague Alesh, who's just sat here with me, we'll be going into a little bit more detail around CHPPD. So we're very much focused on, Mark's talked about the NQB, now obviously we've got the workforce safeguards. We've published documentation and guidance, national guidance around e-rostering and also around CHPPD. And on that note, we are in the process of updating those two documents as well, particularly around CHPPD, just to obviously make sure that we're recognising the new roles that have come into nursing. And also I think it'd be more useful to have a single document as well that's for all providers as well. Okay, so I think I've probably, with some of the slides, sort of listening to the guys this morning, there's a theme that runs through all of our work that very much e-rostering can't sort of stand alone. It's very much links to lots of things. Obviously, the safe staffing agenda, we've talked about retention, recruitment, enhanced care, cost improvement plans, culture, policy and workforce. So all of it is there in terms of where e-rostering can't be just seen as standalone. So we, as a team, do a piece of work with trusts where we'll go in, but we will very much be very clear to people that you're never probably ever going to get your e-rostering right if you haven't got your establishment right in the first place as well. So we often find that we will do an external visit, and then we're sort of on the way train back ringing Anne, one of her colleagues, to say actually we've got some bits we can do around e-rostering, but you know, if you haven't got that absolute basic right in terms of what staff you need, your e-rostering is never going to quite get right as well. So, so e-rostering. So I, like lots of you, remember when e-rostering was implemented, and I think we've learned from how we probably could have do things differently, and particularly trusts that are looking to maybe go to a different provider. We've very much now emphasised having a much more robust clinical front of house lead for e-rostering, particularly to support the utilisation of the software, because what we found as well is e-rostering, essentially some of the principles and particularly some of the KPIs that we want people to start looking at around unavailability and making sure that you've got staff that matches what your patient needs is what a lot of us did in the old days, really. We just did it probably on a management day or at home on a kitchen table with paper and pen, and we do recognise that obviously with changes in grading of staff, it's not always as easy, because you'd always put your E-grade in on every shift, particularly nights and weekends, but some of those principles we probably as a profession need to reclaim a little bit back, and not always be over-reliant of some of our sort of e-rostering teams, because they're absolutely fantastic, but we need to get them to provide us with the technical support. We as clinicians need to really lead this. So e-rostering, so very much around utilising it for your optimum use of the software. So we will have lots of trust. And Anne's mentioned our AHP colleagues, and I'll come on to a slide in a moment about that, that I think nursing has quite a good use of e-rostering. And when I mean use, they've probably got their staff on it from a payroll point of view. But in terms of actually using it to match staff appropriately and make sure they're meeting, Chris made a reference to the percentages of headroom in terms of making sure you're not having too many people on annual leave, you're monitoring all your other study leave, is always used to its maximum potential. There's also something around procurement of e-rostering systems and the need for clinical people, particularly at that executive nursing level, having a awareness of what that means in terms of customer service. We find sometimes our executive nurses sometimes have been reliant on other people to manage those SLAs and sort of agreements with support that can be given to the organisations. And then also we want to really maximise what some of the software can do in terms of the flexibility agenda, which is really key to some of the wider discussions around workforce at the moment, and that can mean, on a practical sense, allowing everybody to use a remote access electronic thing to request shifts, look at the rosters, make requests, swap and book shifts. We are realistic though. I still come across diaries for annual leave. I still come across you know, different bits and bobs, and e-rosters being printed out, put in a folder, put on the ward. Sick leave being in a nice big red pen but not actually transferred to e-rostering. So we know that that's happening, but we need to sort of move on. So I just made reference to AHPs. So within my directorate, we're doing a wider piece of work around electronic workforce deployment tools, and part of that is around trying to get an understanding of the coverage of e-rostering software across the NHS. So we looked at all the different workforce groups, and I think it's quite clear that there is a lack of use of e-rostering tools amongst other professions aside from nursing. And there's something about how we can use some of the good experiences and the good practice that we've done within our profession to help support, like Amy and her team, around AHPs as well. So there is other stuff going on around the deployment tools in terms of levels of attainment. So I'm not going to focus on that too much, but it's again stuff that we will be doing to support trusts to be able to benchmark where they are in their use of the software and be able to sort of understand what they need to do to get to that next level. So, as I said earlier, a lot of what we're talking about today very much matches the themes that have come through already from Mark and Chris's presentation about e-rostering at trust level. So it's absolutely, e-rostering should very much be at a trust level in terms of the understanding of, like, with safe staffing. So the audit that Mark presented was really interesting because it shows that, look, everyone does their fill rate. Everyone will give, everyone will, do their safe staff returns, do their fill rate. It might be, 80%, whatever. It might not have with it, but we don't always have the mitigation explained. And I think when you're a exec or a non-exec at that board level, and particularly for the chief nursing officers, they need to have the absolute assurance that when there is a drop in fill rate, that there's some explanation for that, but also in terms of e-rostering. So well, obviously, most of you should be aware and hopefully are monitoring some of your e-rostering sort of measurements in terms of availability of staff, because some of our more advanced trusts have come to us to say that actually if they've got a trust board that's sort of been coached to sort of look at e-rostering metrics, they're starting to pick up and say, well, hold on, your unavailability for that shift was really, really low, and starting to drill down to see what's happening on a shift-by-shift basis. So I think when we have sort of real-time sort of operational challenges around staffing and people say, oh, well, we've had to have an additional spend for sickness, an additional spend for leave, when you actually drill down, that ward is already exceeding their metrics of their headroom that they've been given. So you've got to start having those difficult conversations to say, actually, you can't have, and we see it, we'll talk about CHPPD, but, we can look at a trust CHPPD and we can see when there's dips, and it will always be on particular weeks in February or particular holiday periods. And I guess, we're aware in the work that we do that we have to balance this with retention and with health and wellbeing and trying to recruit what we've got, but we also have to be financially responsible as well, because we have to, as Anne and Chris would say, that when you are doing your safe staffing establishments and you're looking for enough uplift, you have to give assurance that you're going to manage what you're given as well to a level that keeps our patients safe, essentially. So very much around the KPIs, board reporting. One of the things is joint clinical and technical rostering teams, and I can't emphasise this enough. Where I've seen it work really, really well is where you have a governance structure where you have a sort of responsibility for e-rostering goes towards the nursing teams, executive teams, and also also in terms of other healthcare professionals as well. We can't, as Karen would say, have that situation where you've got an e-rostering team in an office sort of miles away from the clinical situation as well. So we've had some really good examples of trusts that have done that really, really well. So e-rostering at ward level, I mean, we've talked about the workforce safeguards, and I think one of the other things that we can do to support our ward level is, you know, often e-rostering is seen as, oh, the ward manager's problem, oh, it's, you know, they can't roster properly, they let all their staff do what they want to do. But what we've found is actually some of our ward managers, they're actually quite good on the old e-rostering software in terms of using it. It's around them having a wraparound sort of consistent support from some of their seniors as well, and having an understanding of how headroom allowance and staff unavailability in terms of what's agreed and the actual levels is consistently monitored as well. And I guess we talk about this, it's in our guidance around having those rosters produced at a really, you know, obviously 6 weeks, but to try to get it forward planning. Because we've found as well that there's some research going on at the moment around flexibility and forward predictability of shifts as well, and what staff want. So there's some staff would like to know when they're working. That's usually the staff that may need to have a little conversation because they've had the set shift patterns for a long time. But we've got a lot of staff that have other challenges. We know we've got generations now that want to work flexibly, would like to do lots of their shifts in 1 week. Well, that's great, but that's not particularly safe for you or safe for your patients. So it's just trying to understand what is the fundamental reason of why we do the e-rostering and why we do the establishments is actually around the service needs. Reporting as well about transparency of e-rostering as well. So again, we've talked about flexible working as well, but having that regular review as well and having that support and governance within your organisation that if a decision is being made, that's consistent across the organisation as well. So you're not just going to have one ward that has a rule to say, you know, so many people can have this time off at the holiday period, that you have a sort of, you know, that people get to know that this is what we do around here. This is how we work in terms of looking after our staff and making sure that we've got them on the ward at the right time. Looking at your hours, your net hours as well. So we find as well is even though it looks like all our nurses are on e-rostering, we've got a lot of our ward-based nurses on e-rosterers, but we're obviously going to be doing some future work around our nurse specialists, and often they can go on an e-roster in terms of just having a demand template to say they work so many days or what have you. Because what sometimes happens is when you pull your reports and it pulls all your net hours, sometimes those net hours or the anomalies that you'll find is that people are using the system just to record sickness here or just to record annual leave here. And what happens is the systems and the softwares will get a little bit confused and think, oh, hold on, that person hasn't you know, this person hasn't done their shifts. And that, again, can cause alarm at that trust board level because you'll get a finance director saying, hold on, we've contracted hours, people are being paid to do these, what's happened? We talk a lot about the use of auto-rostering stroke system-generated rostering to support safe, scarce skill mix for RNs. And I do get a lot of people coming to me to say, oh, well, it doesn't work, Anna, it doesn't work. But, you know, if you think about it, when we used to do it, you know, you want your nurse in charge, you want a nurse to be able to do other skill sets. So you'll have your sort of skill mix that you've got in, you know, and you can factor that in. If you use the software, you can add those rules, you can add those, not tasks, what do you call them? come to me. But you can add those things that the skills that staff can do, so that it should help to use it. But we're not saying that we want the whole roster actually done automatically, but we do want people to start using some of it, because some of the software has been created to meet not just safety but also some of the stuff around fairness as well. So it helps you as well to have not to have to move away from some of that subjectivity that can make it difficult. And we're also aware that there's software out there around acuity as well, but I think our team are very much aware that we follow national guidance in terms of acuity and probably use more the guidance that we've got as opposed to being over-reliant on software. But it can also be used as an opportunity for redeployment. But again, a lot of it, with all of this, is around professional judgment as well. So we would always advocate that if you have operational challenges around workforce deployment, sometimes it does just take somebody having to go down and eyeball what's happening on that ward as well, particularly with some of our gaps and junior staff as well, in terms of them being more less tolerant to acuity, if that makes sense. So they're more likely to highlight things. So e-rostering process, I sort of touched on this, and I think some of these graphs pictures are quite familiar. So we've got to start off with obviously the strategic guidance, but when we're doing the establishments, a lot of what we're finding is that mismatch between ESR and what's pulled from ESR onto your health rosters, and then also some of the budget stuff as well. So I'm not going to be unfair to anybody in the audience, but we've had situations where a ward manager will think they know what their budget is, but it's very different to what's being held within the finance department as well. So I think just on a practical sense, when you are doing your establishment settings and you're then going to the next stage, it's very good to have your e-rostering team within that conversation, because obviously they are ultimately going to be having to transfer and update what we call the templates on e-rostering to make sure that they reflect what you need as well, because often when we find if we are looking at e-rostering data, it can look very different to what's actually on the shop floor, so to speak. But it's absolutely imperative that you get all of that aligned to be able to make sure that what you're going to be able to use to deploy is matching what you need in terms of the evidence base, but also in terms of the electronic staff records as well, and your budget, which is most important. So hopefully most of you know all of these off by heart and absolutely try to meet them every month. We've talked about the headroom allowance and the usage of annual leave, study leave, sickness, parenting. And it was interesting what Chris talked about having that extra 0.5% for other leave, because that's sometimes where it can get a little bit difficult. And absolutely be honest, it is hard when you may have somebody that needs leave for other we've all got lives, and sometimes people that may not have overt caring responsibilities sometimes feel they're not able to ask for other leave, but they might just use their annual leave for something, which they're equally as important, and we should be able to offer that flexibility. I talked about the skill mix, registered staff, healthcare support workers, making sure that you're not tipping too much the other way. We obviously know that when you are looking at acuity and dependency, sometimes you can, in particular, thinking again about our AHPs, some of those rehab type areas where you may have low acuity but higher dependency, looking at actually the type of nurse that you'd like to have or the type of care support worker that will need to be into that. Again, we've talked about the hours not used per month. Keep going on about that. Again, additional shifts and duties. And again, this is, obviously we know that's happened, and it links very much into the enhanced care work, because often we find the majority of that is in terms of financial sign-off and assurance. Often they're the ones that we'll get in additional shifts for. I mean, obviously sickness and things like that, you should be able to cover that, but we know with the massive vacancies that it's not always difficult. Looking at how much system-generated rosters, again, looking at the bank requests compared to hours worked, number of weekend night shift requests, again, looking at, how are you deploying? I've heard, given that it's so challenging at the moment, often there might be a push for an organisation to put all of their permanent staff on unsociable shifts because it's cheaper. But what that means is that you're never going to fill the gaps in the week, because if someone's doing, to be honest, if someone's doing bank and agency, they're going to try and maximise their income and work the shifts. So it's trying to get that balance yet again, and again to the agency, and then working restrictions as well. So this is again key, looking at what people can and can't work as well, and having those sort of regular conversations around this might be your situation at the moment, that you're going for a particular thing, but actually, because we've got lots of, I'm sure, anecdotal examples where people have had particular ways of working, but the children are actually now at university. But it's also about having those conversations to say, well, actually, we'll talk about retention in a moment, but we've found that e-rostering does impact that a lot, particularly for our newer staff. So this is just an example of some of the KPI monitoring. We know that there's well-known providers that can provide a reporting system that you can pull off automatically, but this is just an example of some of the things that people use, primarily at a sort of divisional level. What we would like to do, and Alesh will talk about this, is within the model hospital, we're hoping to start to put e-rostering KPIs within that. And obviously that's very much dependent on sort of being able to have the data, but it's a way to start to focus people, and actually, what we've talked about around drilling in sort of some of the flashpoints and also looking ahead as well. So I just had a conversation with a colleague about unavailability for, if people are doing their rosters in a timely manner, you should be able to see proactively where you're going to have potential pressure points. So Easter's always a big one, but it's sort of having that conversation to say, look, actually, we're teetering, we've already exceeded our potential for people to go on leave. If we have some sort of flu outbreak, we're going to be, we're going to have a difficult situation. So it's all about sort of forward looking. So this brings us on to one of our other sort of recommendations around e-rostering, is to have check, challenge and coach. And this is very much around supporting those roster creators with their team around them. So Chris talked about or was it Mark? Mark talked about Barbara, who used to help with it, whereas actually that really, for me, is sort of part of the matron's role and the senior nurse's role as well, to help support ward managers with the creation. So where I've seen this done quite well is where you have had all of this representation there, so that there is a sort of assurance, and it brings sort of some of the people there sort of aid-on sort of level. And even, we've had directors of nurse and chief nurses at these sessions as well, to help widen, reduce that gap between ward to board, and to provide that assurance ultimately that, when we are going to start to move towards having rostering at a board level, that there's an understanding that people can articulate what they've got in front of them. And also in terms of the finance people as well, so keep double checking, and also it's sort of a way of looking at, again, the pressure points that are coming on, but also often we find, particularly for those that are new to doing rosters and new to managing a team and managing expectations, they've got that opportunity to have a bit of a place to sort of learn from other people. So, people that have been in that role before, that are more experienced, able to give opportunities. So just talked about sausage resources, because just on a practical level, but again, a lot of this should be very much clinical led. It shouldn't be your e-rostering people giving you lots of reports. They're brilliant groups of people. I've met some fantastic people that work with e-rostering, but they can only do so much. They need to have the clinical leadership behind them to be able to make sure that some of the reports that aren't looking great are acted on and can be resolved. And it really needs to be solution focused as well, and a supportive environment. And again, talked about difficult conversations. I've just realised I didn't mention it was up there, but I'm sure you noticed it, the Ward Leaders Handbook, which does have a section around e-rostering. So that's, again, a resource there. So Mark talked about the retention programme, and we're now in cohort 4, and Karen's team has been asked to support a number of trusts within that. Because what they found from some of the other cohorts is, as we talked about at the beginning, retention very much links to e-rostering. So if you speak to anybody that's, a nurse, they'll just say, oh, just my off duty is really rubbish or whatever. And what we found is, anecdotally, but also some of the sort of exit interviews are showing that people are leaving because they're not often getting their e-rostering right. And I look at a lot of rosters in my time, and sometimes you can see those patterns where there'll be a new band 5 that will come in, and they'll do one day here, day off, one day here, day off here, 3 nights with a sleep day, and you know, it's not great, and often that happens because they're just slotted in. So it goes back again about having that, you know, and are they being slotted in just to fill in a gap, or are they being slotted in because their skill set mix is at? So that's why it's really, really crucial that we use the rostering software to help pick up where there isn't just gaps in numbers, but gaps in skill sets as well. And also we find if we look at the opportunities for work-life balance, which we've talked about as well, e-rostering can help with that as well. So I've gone to organisations where they've not realised they can put things in. So they'll every day just start, every month we'll be starting a new roster from scratch. So we've sort of tried to say to them, you can build in some of these sort of patterns of work and actually use that as well. Once you've put it into the system, you can have that report as well to show where there might be an overuse of fixed patterns. It supports internal redeployment, professional development, internals transfer. So we've found a lot of trusts that are doing quite well on their retention is that they've done sort of internal transfers, and then they can just simply, the rostering team can support to just move that person from one template to another template. And also we can look at the deployment metrics to ensure fairness and transparency and meet and assess patient and curative dependency. Looking at the controlled use of bank and agency as well. A lot of this all feeds into the retention as well, so you'll get a lot of people working on rotas that have got some shifts have got a disproportionate amount of temporary staff into other shifts. And again, it just goes back to how you're using your core staff, and I appreciate there isn't that because of the vacancies. And then just optimise the availability and participation in co-production. So again, an example is a trust that we visited, because we do it at Christmas, right? Like every September, everyone's like, what do you want to do, Christmas or New Year? But it's about having that maybe just throughout the sort of work within your team that you're doing your rostering for, to look at what people can and can't do, and having those adult conversations, but have that within a governance structure that means that, you know, you're obviously not going to leave things where you've got no staff. So again, we've talked about the workforce safeguards, and I think Lorna's going to talk about this as well. But again, it's very much just to sort of say that the e-rostering theme is within this as well, to sort of make sure that we're using our rostering effectively to meet all of those things, and about the alignment of practice of processes. And again, just getting you to think about how, when you do in your establishment setting, not thinking, oh, it's fine, we can just give that to the e-rostering team. You still sort of need to be involved with that, and the ongoing sort of assessment of that as well, and regular reviews of the e-rostering as well. So that's a whistle-stop tour. And I've just put up here our contact details as well, and I think we printed off some copies of some of our guidance. It should be outside, but they're also available on the NHS Improvement website as well. But as Anne says, I'm going to be here for the rest of the day, so obviously participate in the Q&A, but also if you want to come up to me afterwards, because sometimes e-rostering is a tricky one. Thank you. Okay.